Welcome to Stroke News Episode 2. Today we discuss one of the most significant advances in acute stroke systems of care, mobile stroke units or MSU, and the clinical evidence supporting their expanded deployment. A mobile stroke unit is a purpose-built ambulance equipped with a portable CT scanner, point-of-care laboratory, intravenous thrombolytics, increasingly tenectoplase, and telemedicine infrastructure for real-time neurology consultation. The concept is straightforward. Rather than transporting the patient to the stroke center, we bring the stroke center to the patient. 3 landmark trials underpin the current evidence base. The Phantom S trial in Berlin demonstrated that MSU deployment reduced alarm to treatment decision time from 76 minutes with standard EMS to just 35 minutes, a saving of 41 minutes. Golden hour thrombolysis rates rose from 37 to 58%. The Be Proud study, published in JAMA, showed that MSU dispatch was associated with significantly better 90-day functional outcomes, a common odds ratio of 0.71 for a worse modified Rankin scale score, with 90-day mortality falling from 8.8 to 7.1%. The pivotal BEST MSU trial, published in the New England Journal of Medicine, enrolled 1,515 thrombolysis-eligible patients. Median onset to treatment time was 72 minutes with the MSU versus 108 minutes with conventional EMS. Functional independence at 90 days, a modified Rankin scale score of 0 or 1, was achieved in 55% of MSU patients versus 44.4% with standard care. Mortality was 8.9 versus 11.9%. Symptomatic intracranial hemorrhage rates were equal at 2% in both groups. Particularly striking is the golden hour thrombolysis data. 1/3 of MSU patients received thrombolysis within 60 minutes of symptom onset, compared to just 3% with conventional care. Given the established time-benefit relationship for thrombolysis, this represents a categorical shift in outcomes, not merely an incremental gain. In rural settings, the benefit may be proportionally even greater. Baseline delays are longer, so the relative time saved by MSU deployment is more clinically meaningful. Modeling data shows that MSU coverage increases thrombolysis eligibility by up to 279% in rural populations using a 3-hour treatment window. MSUs also strengthen the thrombectomy pathway. Units equipped with CT angiography can identify large vessel occlusion pre-hospitally, initiate tenectoplase as a single bolus on scene, and divert patients directly to the catheterization laboratory, bypassing the emergency department entirely. The Memphis experience confirmed this approach significantly shortens door-to-puncture times. On cost effectiveness, a 2025 prospective multi-center analysis published in the Annals of Neurology reported a lifetime incremental cost effectiveness ratio of $94,710 per quality adjusted life year across all eligible patients, falling to $31,259 for patients without pre-existing disability, well within accepted thresholds in most high-income health systems. Barriers remain real. Setup costs range from $1 to $1.5 million, with annual operational costs of up to $1 million. Access to vascular neurologists is the primary staffing constraint. Reimbursement frameworks lag behind the evidence in many countries. In rural areas, telemedicine models depend on reliable broadband connectivity, which is not universally available. Despite these challenges, the 2026 American Heart Association and American Stroke Association guidelines have issued a Class 1 Level A recommendation, their highest, stating that where available, mobile stroke units should be used over conventional EMS for thrombolysis-eligible patients to achieve the fastest treatment times and improve functional outcomes. The question is no longer whether MSU work. The data is unambiguous. The questions now are how we fund them sustainably, how we staff them at scale, and how we extend them to the rural and underserved populations who stand to benefit most. Thank you for watching Stroke News. Tomorrow we cover loperamizole, the first neuroprotective agent to show genuine promise in a randomized stroke trial, 30 years in the making. Subscribe so you do not miss it. Stay evidence-based and act fast.